Good afternoon. We are ColoCare, closing the gap in colorectal cancer care using a continuum reform-based model. I'm Pranali.
I'm Rishi.
I'm Johan.
And I'm Aisha. Here's the roadmap. We'll talk about the problem, our three initiatives, funding and cost, and long-term inequity. But before we get to the solutions, let's talk about who the system is failing the most. In Minnesota, Hispanics aged 50 to 75 have a recommended CRC screening of 57%. This number in Asian patients is an 81%. Black, Indigenous people of color have the highest incidence and mortality rate from CRC of any group in the state. These are not just statistics. They are communities where the system has consistently been falling short and how our interventions are meant to help. Reform here is crucial due to the Minnesota paradox. Minnesota is one of the healthiest states in the nation, yet has one of the worst racial health disparities. Black, Indigenous people of color have dramatically higher CRC rates despite world-class healthcare being available. To combat this, we need alignment across 5 groups: the healthcare system, care coordination, community, digital infrastructure, and patients and survivors. The partners to do this already exist in Minnesota. We have the Minnesota Community Measurement, the Cancer Alliance, EPIC, SAGE, and patient advocacy organizations like the Colon Cancer Coalition, which can help make our success better since they are local and easier to implement.
Discontinuity begins at diagnosis, so here's where our initiative begins, the patient nav. The system's issues are verbalized through Lauren's story. What if the radiologist reads it too late? Or the pathologist has too many cases? Those lost days, could they cost me everything? To understand the system, we have to understand its 2 root issues, delayed action and patient compliance, because understanding the problem contextualizes the solution. So on one side of the spectrum, we have delayed action. A research study published in 2017 found that for all CRC-related treatment delays, around 40% of those were found to be systemic factors, breaking that number down into 18% being physician-related delays in the form of late referrals or ignored altogether, and 22% of those being administrative level in the form of failed communication with the administration and patients. But on the other side of the spectrum, we have patient compliance. Another study published in 2025 found that for all CRC-related abnormal results, upwards to 56% of all patients failed to follow up with their 1-year diagnostic colonoscopy. And that number gets dramatically worse when it comes to in-person care, at around 10% overall. So as we can see, the issue isn't with screening itself, it's with seeking it out. But our initiative addresses both sides of the spectrum, introducing the patient nav, which centralizes point-of-care contact to utilize community health workers to bridge the communication gap between physicians and patients to make communication seamless and make sure no information is lost in the framework. Here's how a simple model of ours would look. Community health workers would act as the middleman between physicians and patients, making communication seamless. And on one side of the system, they would work with physicians to make sure they send consistent follow-up reminders on lab results, and in turn, physicians would provide those lab results along with recommended follow-up action, which the community health worker would then effectively communicate towards the patient of interest, providing them with lab results, risk stratification scores, and recommended follow-up action. And in turn, patients confirm follow-up action and diagnostic colonoscopy scheduling. I mentioned risk stratification in my model, but let's look at how that would actually work. As you can see, patients will be categorized from low, medium, and high risk based on underlying conditions and biodata. That way, physicians can redirect their resources to the patients who need it the most. I talk all about this model in theory, but our evidence backs us up. A similar model was implemented in the past, utilizing a positive fit registry, physician reminders, and nurse navigator tools. And the result was a shocking 92% follow-up action rate. We'd be implementing a similar model, but let's look at why we utilize community health workers specifically. A similar model used community health workers to address social barriers between administration and patients. And what they found was a 10.5% median increase in return action rate. But obviously, an initiative is only as good as its costs. We estimate PatientNav would take around $400,000 annually for system maintenance, mostly directed towards salaries. But when you take into account late-stage CRC treatment and expenses, don't think of this as a cost. Think of this as an investment. Our implementation model would follow such. We'd begin our pilot launch at the University of Minnesota flagship program, then move to integrating our system-wide across the rest of mHealth Fairview's hospital systems. But our ultimate goal is expansion outside of Minneapolis, partnering with federally qualified healthcare clinics to address local screening in high disparity zip codes. But improving screening can only take you so far. So what happens when a patient is actually diagnosed with colorectal cancer?
That's where our second initiative comes in. We introduced the Web Advisor. Listening to Lauren's story, we realized that she was constantly fighting battles with her insurance providers, as well as facing a decentralized appointment system. Listening to this, we realized that patients often face a wide variety of issues that fall into three main problem sets. First, insurance delays. Second, patient management. And third, duplicated care. In terms of insurance delays, it isn't actually the incompatible insurance providers. Instead, prior authorization delays. Because of these delays, 34% of events end up causing an adverse effect, and 80% completely discontinue treatment. In terms of patient management, out of the average 400 minutes spent on treatment every single week, only 104 minutes are actually spent in the hospital. Outside of that, it is instead spent on travel, scheduling, and other things. In terms of duplicated care, it was noted that 40% of primary care physicians were unsure of whether their treatment was being duplicated across other oncology departments as well as private healthcare facilities. On top of this, 74% of primary care physicians were unsure of how to provide proper feedback on duplicated care. And this duplicated treatment results in a total cost of roughly $100 million per annum. And that is where we come in. Our CRC Web Advisor will be able to take in the patient's medical diagnosis, geographic location, insurance information, and real logistical barriers for their treatment, and offer a personalized timeline that will offer the best healthcare providers in their area, reduce PA delays, as well as offer solutions within their area for logistical barriers. We'll be working with local Minnesota computer science students, public health majors, social workers, as well as the oncology departments and mHealth Fairview's service line director for implementing this strategy. Now, to see if it works, we actually researched into the fact that a prior study conducted showed that there was a 65% reduction in PA denials when a system was used, and when a rideshare provider system was used in patient usage, there was actually an increase from 53 to 94% in appointment attendance. Our costs show that we will have an initial startup fund of roughly $200 for building the website and roughly $1,200 for an annual maintenance fee. And to alleviate these costs, we will be using non-invasive, non-pop-up ads on our website to generate roughly $350 to $500 per month. With this additional revenue, we will be able to offer stipend positions for computer science students that will also be working with Minnesota public health majors to actually build the algorithm and website for our first stage in our implementation plan. And for our second stage, for months 6 through 12, we'll be working with Minnesota oncology departments as well as social workers to maintain the best logistical barrier solutions and the best healthcare providers in the area. And our final stage, we'll be working with the mHealth Fairview service line director to maintain the active users and watch for adjusted timelines. But treatment is never the end.
Which is why our last initiative goes beyond the clinic and into survivorship, which spans across a patient's lifetime post-treatment completion. We see in Lauren's story that she is content to just sit back and enjoy every precious moment. But unfortunately, her oncologist reminds her that she still needs to go to biannual checkups and is always careful to never use the word cured. That's because Lauren is not an outlier. Only 56% of CRC survivors actually complete their required 1-year surveillance colonoscopy. When you break that number down further, that's 76% going to office visits, 48% to colonoscopies, 10% to CT imaging, and across all surveillance modalities combined, only 38% of survivors actually follow through. So where's the gap coming from? It's the survivors themselves, who believe that they are done with treatment. But the unfortunate truth is that cancer can reoccur in 30 to 40% of cases where CRC patients have finished up their treatment, and 90% of which are occurring within 5 years of surgery. On the flip side is the administrative end, where there is not one party that is assigned ownership of ensuring that a patient is actually following through their required plan. In Emil Fairview's case, there is a survivorship program in place, but it provides recommendations, not enforcement. That's where our initiative comes in. Once the treatment is completed, the oncologist will trigger a patient surveillance calendar on the Epic Beacon module and assign an available nurse navigator. The patient will then be handed off to the nurse navigator in person if possible, and also be given a pamphlet and one-page care plan to underscore the importance of surveillance. When the patient gets back home, they'll receive automated reminders on the MyChart app 60, 30, and 7 days in advance, telling them to schedule their surveillance tests. In the case that a patient doesn't schedule within 2 weeks in advance, a nurse navigator will be alerted to ensure that they can uplift any barriers, and in the case that there are any issues that are too socioeconomically complex for the nurse navigator to handle, a social worker will come in and be added into the referral pathway. Our evidence is rooted in 2 major studies that found that automated patient reminders actually increased colonoscopy completion from 52 to 86%. Additionally, nurse-led follow-up was seen to improve overall adherence to screening protocol post-treatment completion, which informs the major facets of this initiative. Our overall cost will be $300,000 per year, which includes nurse navigator salaries, a one-time EHR configuration fee, outreach materials, and the MyChart messaging configuration system. We plan on starting our implementation at Amherst Fairview and ensuring that the EHR system is configured. From there, we will expand to the Southdale and Ridges Hospital within the campus, and in the long term, we plan on improving overall understanding of surveillance within patients. Our funding will actually come from the CPT code 99490 that provides a net reimbursement rate per month for each clinical member, such as a nurse navigator that spends up to 20 minutes of time with a patient. In this example, it provides the hospital a net reimbursement rate, annual reimbursement of $140,000 for each nurse navigator that they employ. Now I'll hand it off to Maisha to speak about cost, funding, and return on investment.
Our year 1 cost is $650,000. Majority of this goes towards the patient nav and survivorship staffing, while the web advisor is only $1,360 thanks to the help of student volunteers. We've identified 4 strong funding processes. We have the Masonic Cancer Center Pilot Grant, the Angel Foundation, the Minnesota Community Ideas Program, and the Blue Cross Blue Shield Minnesota Healthy Together Grant, which can realistically cover our year 1 costs. Over 3 years, we project $45 million or more in healthcare savings thanks to the help of earlier detection, and a calculated ROI of 6,800% with every dollar invested, 68 returned. Long-term impact is dependent on a strong equity lens. To do this, we'll track outcomes by race, language, insurance type, and neighborhood with culturally competent outreach prioritizing Somali, Ojibwe, and Spanish-speaking communities. Ultimately, we envision a system where the patients aren't navigating alone, where follow-up is automatic, roles are clear, and no one is falling through the cracks. Our goal is to make sure that every patient has trust in the healthcare system. Do you remember Lauren? Under this model, her CHW reaches out before she has to ask. Her treatment is mapped out, her colonoscopy has been scheduled. The system came to her, and that is what lower patient burden actually looks like. Thank you so much.